Hello, everyone, and good evening for all the people in Europe, and good morning for all the people in US. This week is a very important week. Is the Shockweek with Vascopedia. Essentially, 3 days of cases, live cases with, of course, comments from faculty, and actually a discussion about this new technology. I mean, sort of new technology, which is taking more, having more and more funds around the world. Essentially, today we have the pleasure to be live for Bad Krotzingen with Dr. Elias Noory. And we thank him for his presence in the lab. As usual, he's a master of recanalization, and actually we have a very estimate faculty, which is made by three great clinicians. One is Professor Athanasios Saratzis from Leicester in the UK, then Dr. Bella Huasen from Bolton, still in UK in Lancashire, and then Dr. Enrique Alejandre Lafont from St. Gallen in Switzerland. So essentially, we are gonna watch the Dr. Noory doing a live case, and then we're gonna switch to some case presentation with recorded cases and some more discussion. So, Elias, you're ready in your cath lab, aren't you?
Hello, Lorenzo. Thank you very much for introducing me. Dear colleagues, ladies and gentlemen, it's my pleasure to present a live case. This is 68 years male patient with a TAOD according to Rutherford 3 to 4 at the left side. So he has a calf claudication with a walking capacity of only 10 meters, and he feels some foot hypoesthesia at rest. He was already treated just some weeks ago with a recanalization and lithoplasty and stent PTA of the right CFA. His risk factor are nicotine abuse, hyperlipoproteinemia, arterial hypertension. Next slide, please. The non-invasive examination showed that ABI at rest at the right side 0.8 and at the left side 0.4. And the duplex scan showed heavy calcified femoropopliteal artery stenosis and a subtotal occlusion at the distal part of SFA. As you can see in the duplex scan, next slide, please. There was a lot of calcium with a completely a shadow. It wasn't possible to detect the color, as you can see, and just a very small flow with only 20 or 30 centimeters per second. And the popliteal artery is reperfused, but with a monophasic flow profile. Next slide, please. So this is angiography from the left side, which was done
Okay. Wait a second. Let's go back to the slide before, because I mean, before your plan, I would like to hear from the people online what they would do. Can you please come up with the first poll? So essentially, it's a lesion at the level of the distal SFA, which is one of the segments where the vessel usually bends more together with the popliteal. So I mean, to me, it looks like what we can call a no-stand zone, and I think we all agree with that. And actually, the poll is asking to you, can I see the poll on the screen? We'll ask to you which kind of treatment would you prefer? Would you be your first line treatment? Essentially, it's a treatment that needs to be done. Of course, the wire needs to cross probably intraluminally. I don't think there's a huge difficulty in doing this with an O14 wire, but then you need to choose the treatment. The poll for this, like the treatment, is the sequence. How would you approach this lesion? So one option is the POBA, so single normal angioplasty. The second option you can vote is a directional atherectomy. The third one is rotational atherectomy. The fourth is the scoring or cutting balloon, so some special balloon, or if not, fifth option, IVL. So it would be nice to see which are your thoughts, guys, the ones who are online. So let me ask, for example, to Thanos. Do you want to go through the options? What do you think is feasible in such a lesion?
I think to start with, it's a graded or a stepwise process. So I think you need to stay intraluminal, and like you said, I would start with an 014 wire and do my very best to stay intraluminal. then POBA for me probably doesn't have a place here. I think you'll see quite a lot of recoil plus minus dissection. It is eccentric. I'm not seeing the full duplex or cross-sectional pictures, but it looks eccentric to me. So I would probably start with IVL here because of the degree of calcium that I can see. But the main thing is that I want to stay intraluminal and keep all my options open.
Okay, I think it's a very wise plan. Now, if we can see the results of the poll, and so it's good. So essentially, Thanos, probably they listen to you. No one is gonna would use the POBA because, as you said, I think that we can discuss it later also with Elias. The rate of dissection in such a lesion could be quite high, so you wouldn't end up stenting this lesion probably. 25% would use the directional atherectomy. Rotational atherectomy at the 25%, and 50% would use the IVL. So, do you want to, Rick, do you want to comment a little bit on why would you not, for example, or would you use a directional or non-directional atherectomy in such a lesion?
So I like atherectomy a lot, as you know, but in this case, my experience with heavy calcified lesions is that the directional atherectomy is not effective enough and causes a lot of embolisms, or at least you have to work with a filter, and you need a lot of time, and maybe you will always slip. If it's eccentric, you will slip from the calcium and go inside the softer tissue, and then you might even perforate. So I think I wouldn't do unidirectional atherectomy in this case, so I would choose IVL too.
Okay, I think it's definitely a good explanation. Also, the jet stream, for example, would probably go towards the place where there's less resistance, so it will just scrape this. As Thanos really wisely said, it's not like a concentric calcium; it's also eccentric, so it will just scrape the surface of this plaque going somewhere else. Okay, so Elias, now because you are the operator, you are the magician, so tell us what you think and how you're going to treat this lesion then.
Okay. Can you show me the next slide, please? Okay, so this is my treatment strategy. I have already placed a 7 French sheath at the left groin, an antegrade approach. I will take a 0.14 inch guide wire to cross the lesion, and maybe if necessary, independent of the lesion, if there is really a completely occluded part, so I would make a pre-dilatation just to avoid to damage the shockwave balloon catheter, and that is also my treatment of choice: vessel preparation with shockwave followed by DCB, and if necessary, I would cover the lesion with a short stent like Super or something.
I think it sounds like a very good plan. So let's see where you are then on the case. Let's switch to
Can we
live,
switch now to the live screen? Yeah, well.
Out of interest, what wire are you using for your 014? What's your preference for this?
Excuse me?
The wire that you're using, what's your preference? Your 014 wire?
I have a 0.14 inch from Terumo at Radio Focus Advantage wire.
Definitely, I think it's for all the viewers. The first wire that you use, or whatever brand it is, could be Abbott, could be Terumo, could be Codis, any brand. It needs to be probably soft tip wire. I think we all agree on that as a first attempt, in order not to, you know, perforate or damage the vessel. If then probably in the algorithm, like everyone should have also CTO wire in case you can't cross, you don't have enough penetration, but it's always a second choice. So I think it's we all agree on the type of wire. Then, you know, the different, of course, different types of brands, but a nitinol with the soft tip and hydrophilic tip, I think is the best. Okay, so exactly. Yeah, show us.
Do you see now the live screen?
We do.
Okay, that's now just a fluoro from the target lesion. As you can see, there is a heavy calcified SFA at the distal part. And I'll show you now the angiography from the origin of SFA downstream. So it is a very big vessel. So I show you now the target lesion in conventional angiography, but also in DSA. And as you can see, I already made a measurement of the reference vessel. It's like around about 7 millimeter. And at the distal part, which was not described in the duplex scan, there is also in the popliteal artery stenosis. The popliteal artery also at the middle part with a tandem stenosis around about 70%. There is the vessel only 6.2 millimeter, and below the knee there are two vessels run off via anterior tibial artery and peroneal artery with a very nice dorsalis pedis.
Typical heavy smoker. So my question is for you. So this is a patient which I would classify as a Rutherford 3 to 4. Are you willing to open just this SFA, which is badly stenotic, or also do you want to tackle the popliteal?
So I would say it would be better to revascularize him completely. So it is not really an occlusion of the popliteal artery. In case of an occlusion, a collateralized occlusion, so I would leave it only by SFA, but in this case, I would treat also popliteal artery and SFA.
Very good. Do you plan to use shockwave for both lesions?
Yes, that's the question. So now the first question is, which size should
exactly. And
choose
that's the poll. That's the poll. So bring up the poll, please. So essentially, as Elias said, I mean, there are different ways to measure the artery. There's people who are measuring it under CT, if they do the CT. I personally don't. There's people measuring under duplex. You can ask your technician to measure before and after in order to have a good sizing. There's people measuring with IVOS. So essentially, especially in US, you put the IVOS in and you get a good size. And actually, there's the last thing, as Elias did, there's also the calibration with the catheter, which is within the patient in order to understand the diameter. So having said all these kind of possible different measures, in your experience, in this case, which size of balloon would you use? And actually the options are, option number 1, 5.5 or smaller as a shockwave treatment, okay? Not mentioning the pre-dilatation as Dr. Noory said before. 5.5, the first option. 6 millimeter is the second option. 6.5 is the third option. 7 millimeter is the fourth option, and guess what? 8 millimeter is the fifth option. So I give you a little time to think about it, and I will ask people, you know, Dr. Huasen, how do you usually measure the vessels in your center? Just generally speaking, of course, every case could be different, but do you, for example, do you do CTs for all your cases?
Almost all are CTA or MRA. Traditionally, probably you would have some idea from the CTA and then the rest is done via the angio, but I'd say within this year I've moved on to Doppler on the table. So I would do it myself, and I found that a lot more accurate.
Okay, that's very nice. Essentially, I think it's a very much cheaper way, in a way, to measure. Also, less struggle for radiologists in order to report the scans. So anyway, okay. Having said that, let's have a look to what people think about this sizing, because also it's important then to discuss why the balloon should be sized in a certain way. So let's have a look to the results of the poll. I'm very curious, and I hope that people. Oh, that's very nice. So essentially, most of the people would go, definitely most of the people would go for 7 millimeter, and 1/4 of the people would go for the 6.5. I mean, I will ask Dr. Lafont to discuss about these results quickly, and then we'll see what Dr. Noory has already the balloon. So he didn't vote, but he already has his idea. So Enrique, what do you think?
So I recall that the vessel was about nearly 7 millimeters, right?
Mm.
Exactly.
So I would use the 8 millimeter shockwave.
8 millimeter. Thanos,
Yeah.
what would you do?
If I was treating just the proximal end of it, probably 8. Yeah. Yeah, I would say 8 millimeters. But again, I don't do my sizing these days based just on the angiogram. I would probably, especially for a claudicant, I would like to be very precise with my sizing. So I'd get the IVOS out if I could.
Okay, Bella?
Yeah, 8.
8. Okay, so essentially, I would just want to remember to refresh one thing. There's also the popliteal lesion to be treated. And
Yeah.
actually, you know, it's very important, just as a general feeling, we all know that, but it's good for the viewers, that the IVL needs to be size 1.1, essentially, if at least the same size of the vessel, but even because low pressure, go a little bit higher. So maybe with one balloon, we can get rid of both. With a 7mm balloon, what do you think, Elias?
So my idea was also to take an 8mm balloon. The question is, what should I do with the popliteal artery? And in my opinion, I think it would be possible to go with the 8mm, but only with 1 or 2 atmosphere, give only 2 or 3 shocks in the popliteal artery. And I would cover cover the lesion then with a 7mm DCB. And for SFA, clearly 8mm, that would be my choice, yeah.
Okay, but we all agree that no one would go below the 7, am I right?
Exactly, yeah.
Because that's a very important message, I think, to pass. So very good. Okay, so now Dr. Noory will inflate the balloon, and in the meantime, I will ask also Dr. Huasen, who is so kind to explain us which are the new features of the M5 catheter. So from the packaging to the you know, how quick are the pulses.
So I'm going to focus on the packaging. So I don't know, some of you would have been in the older generation where it was just the catheter and you had to use different ultrasound probe covers and cut them and DIY yourself. So I'm very pleased that the new kit now is all included, the cover, the sticky, whatever you need. So you don't really need to get anything else out. So that's important in terms of staff and prepping. It cuts off a lot of steps and keeps everybody happy. I think, thanks, you agree with me that the fact that the packaging is there.
But look, also Elias is rapping very nicely, you know, like it's, I'm always surprised when the people from Germany, they work completely on their own, you know, they don't even have a scrub person. So it's amazing.
Exactly.
We're very fussy, you know, we're very spoiled about having a scrub nurse. So he's doing everything on his own. So I think also he's happy about his new package. So, okay, so you're treating the popliteal lesion first, am I right? Did you do any pre-dilatation or you're going directly with the balloon?
So I already done a pre-dilatation, but only at the SFA with a 3mm balloon. I can show you, here is it. So it was just a pre-dilatation with a 3mm balloon, as I already mentioned, just to avoid to damage the balloon catheter, the shockwave. And I will start now with the popliteal artery with only, I would say, 2 or 3 cycles
Okay.
in the popliteal artery, and then I pull back the balloon catheter in the SFA.
Okay, and you see the light going on, and you see that the new catheter compared to the old one, I don't know how many were used to the old one, has double the velocity, and actually it makes the intervention quicker and actually all the operators happier. So essentially, I mean, still there are 300 pulses and divided, of course, in 10 cycles. So in a lesion which like this, Dr. Noory said is going to use 2 to 3 cycles for the popliteal and the rest for the SFA. It's also important to mention that the marker in the middle has almost double the power of the normal other markers. So if you have a spot of calcium, which is particularly difficult, it's important to inflate the balloon accordingly to put it the central marker at the level of the most tough calcium. Is what you all do. Thanos, do you do the same? Okay, so yeah.
Yeah, absolutely, yeah.
Okay, and you see now Dr. Noory is moving the balloon a bit in order to treat the whole segment, but I think it's very important to keep in mind that, of course, the central marker is definitely the most powerful. So you see, and Dr. Noory, would you like to explain to us and to the people who are more junior, what's the inflation? You know, how many atmospheres do you inflate the balloon?
So I didn't usually for SFA in this case, I would go up to 4 atmosphere only and give some 30 shocks, and then you can go up to 6 atmosphere, but in the majority of cases, is it enough, not more than 6 atmosphere. And that's also the reason that we avoid in the majority of cases a dissection, you know. So that's only a low pressure dilatation with a with this shockwave balloon. That means 4 atmosphere with activated shocks means that's around about 50 atmosphere. So we induce a microfracture of the superficial and deep calcium, and we achieve a much better compliance of the vessel with a very low pressure.
I think that's very wise. So essentially, the only thing you want is the balloon to be in contact with the calcium in order to get the most powerful power of the device, in order to crack the calcium. And Enrique, for example, what's your algorithm? Do you start at 2, then you upsize to 4, then from 4 to 6? What's your algorithm instead?
Well, I looked at, I have full contact with the vessel wall, and then I start the IVL, usually not really depending on the pressure. I start with the lowest pressure, and then I look at the beginning if the pressure falls, which means that the IVL is working. And so I maintain the pressure at the level. As long as I see an effect, I stay at this pressure, and if I don't see an effect, I go maybe up to 4. Usually if it's the SFA or popliteal artery, I think you can start with 4, but in this case, with an 8 millimeter balloon in the popliteal artery, I would start with 2 atmospheres and watch the balloon and see if it works.
I think it's very wise. Again, we need to increase the violence step by step. Of course, the plaque changes its own elasticity doing our ballooning. So essentially we can upsize a little bit the atmospheres, but very gently, because what we want is not to create dissection. So essentially we just want to crack this calcium. And any comment, Bella, do you want to comment on why possibly the shockwave has such a, I would say low, but I would say almost no rate of embolizations? What happens in the vessel?
I think it's just getting the concept of understanding that these are sonic waves. You're cracking. It's not that you've got a balloon here to PTA. It's almost like a molding balloon and then shocking through ultrasonic waves, which then is this concept I had to get my head around at the beginning, because I was scared that you're going to crack and trash, but that's not the point. It's not a PTA balloon. The other concept to get around is that this is part of your scaffolding for whatever you're going to do next. It's not it all be all and that's it. So this is more that it will help the compliance of your vessel so that you can then proceed. So because you're cracking, you're not actually working as a final treatment. You shouldn't, in theory, see any distal, touch wood. As of yet, I haven't seen it.
Yeah, also, I mean, they are both, and then Thanos will present some data, but both the randomized control trial and the large, observational trial, they don't show any case of embolization. So now, Elias, now you're treating the most stenotic part, am I right?
Exactly. Now I'm at the distal part of SFA, and I already gives 2 cycles of shocks, and as you can see, the balloon is maybe completely expanded. With
you're doing well with no air bubbles, which is fantastic. I think it must be your 3-way tap system. I'm very impressed by that.
Yeah, it's very important to mention that. Thanks, Bella, because I mean, as many radiologists probably will know, and when they scan very large and distended bowel patients, the worst enemy of the ultrasound, so diagnostically and during your intervention with shockwave, is air. So essentially, it's important that you don't have air bubbles in your balloon in order to maximize the use of and the passage of the sonic waves. So essentially, Elias, I mean, you have the proof of validity from Bella, and then you're doing a great job with no air into the balloon. Yeah, well done.
Thank you. Yeah, that's really very important to prepare the balloon catheter before we start. So we make a deflation several times just to be sure there is no bubble. It's a very important point, yeah.
And you're doing all of this, like Lorenzo said, without staff. We're used to the luxury of at least 2 radiographers, 2 IR nurses faffing over.
Oh my God. Yeah, and US is maybe everything possible, but we have to save a lot of money here and for the hospital, you know.
But at least you have some friends here online to keeping you, you know, company, because if not, you would have felt very alone. So
Yeah,
And out of interest, the patient, is it a local anesthetic, a regional block, a GA? What are you doing for your patient?
only with local anesthetic, yeah.
and do you do the GA yourself also, or do you sometimes you have anesthetist?
No. Everything by myself.
Okay, they told me also you're a very good porter, and you after you finish and you clean the room and you bring the patient back to the ward. Am I right?
No, that's not. But so the treatment is by the doctors alone, you know, in the majority of cases. So sometimes we have also some fellows here in our cath lab, but in the majority of times,
I'm not sure I want my hospital to be listening to this part. Shall we focus back on Shockwave?
Yeah, that's very good. I mean, actually, you almost finished with your cycles. Am I right? How many cycles do you still have?
So now is it the last cycle, and you can see now EOL, end of life, is achieved. So it was 6 cycles in the SFA and 4 in the popliteal artery. And I will give you now an angiography before DCB.
Sure.
Then
so, Thanos, because you are a scientist instead of a plumber like me. So I'm asking you, in such a lesion, how much difference you think that a DCB does compared to normal POBA?
Well, if you look at the mechanics of DCB, it wouldn't really make much of a difference if you compare it to POBA just from a mechanics point of view, right? A DCB is practically an angioplasty balloon. In terms of what difference does it make over longer-term patency, well, unfortunately, the studies have not really stratified outcomes with regards to patency based on calcification. There's a number of series out there that have done regressions to look at whether calcification defined in all sorts of ways does impact on patency, but I cannot really answer your question with hardcore data.
No, I mean, I know that's why I asked the question. So if you don't have data, no one has data. So essentially, it could be a good discussion about which treatment is best. And wow, that's great.
Look at that. That's really a very nice result. Yeah.
Yes. I mean, like this is like it's when we say that a Shockwave is not a standalone treatment, but almost is, because I mean it creates the basis then for just an angioplasty, a simple POBA probably would do even the job. So yeah, let's have a look also to the popliteal. It's very nice to see that there's no dissection, and actually the flow is very brisk, and the diameter is definitely the right one. So definitely 7 millimeter was the right answer. Well done for people who said 7 millimeter at least. So let's see now the popliteal. Ready, steady, go. Yeah, it's good to protect yourself with the screen, because people like passing all the day in to the cath lab. Okay, that's a very good result. I still see a little bit of stenosis in the popliteal, which is actually fine because we're gonna do still the POBA. So as we said, it's a good vessel prep tool, and let's see what happens then. Which size of balloon would you use now, Elias?
So I would take now a 7 millimeter DCB for popliteal and 8 millimeter for SFA.
Okay, that's a very good plan. So in the meantime, you do this. Why don't we go for Thanos? You're gonna explain a little bit about the data and the case, and then we can come back to you. What do you think, Elias?
And yeah, it's okay. It's okay. Perfect.
Okay, so Thanos, the floor is yours. You can show us what you have prepared. Okay, here we are, data now in English.
Great. So I'll spend a few moments to just go through some data with regards to calcified FEMPOP lesions from the Part 3 randomized control trial. Just as a reminder, this is an efficacy trial with a primary outcome of procedural success. And it's important to know how they defined procedural success. So it was defined as residual stenosis after your primary treatment of less than 30% without a flow limiting dissection. And I'll come to it in a sec as to why this is quite important. But then the study was actually powered in order to look at primary patency at 1 year as well. So you could say that primary patency at 1 year was in a way a co-primary outcome measure. About 300 patients, the vast majority had very calcified de novo FEMPOP lesions, and half of them were randomized to receive IVL as the primary treatment before DCB, and the other half were randomized to receive as a primary treatment plain balloon angioplasty. 45 sites, about 300 patients. The important things to note here, these were severely calcified lesions, and that is very unique in the literature because all of the other trials funded by industry in the FEMPOP region, they don't really specify the degree of calcification, and we're also looking at 13 centimeters of average length. With regards to the early results, using IVL as your primary treatment has got superior results in terms of procedural success when you look at their primary of residual stenosis of less than 30% without a big dissection. And it is an atraumatic treatment. There was 77% reduction compared to PTA as your primary treatment. There was a 77% reduction in type C. That's the bad flow limiting dissections. There were no embolizations within the IVL group. There were no vessel preparations. And the dissections that they had seen did not affect flow distal to the treated segment. And it reduced bailout stenting by 75%. So that's a 75% absolute risk reduction when you compare it with plain angioplasty as your first treatment. Primary patency 2 years was 74% for IVL and 57% for PTA. There's a cohort study as well out there which looked at different areas rather than just the FEMPOP segment. So what we're looking at here is a cohort study or observational study of 700 patients. And we're looking at other vessel beds as well, like the iliac arteries below the knee and the common femoral artery. And why is that important? Well, it's important because the results of IVL were excellent across all vessel beds, and they were at least comparable or actually in most cases superior to treating the lesion, the calcified lesion, with a PTA primary treatment. So that's all I had to say about data. I think this provides quite a lot of decent evidence, randomized evidence from an efficacy point of view. The treatment is definitely feasible, it is definitely safe, and there's now decent 1 and 2 year outcomes with regards to patency.
I think it's a very nice presentation about data. And actually, before going back to Elias, I will ask, we discussed about also the amount of cases as we do in a year, and actually Enrique has an incredible number. So it's like this year has done 100 cases with Shockwave. So it's he has probably is the one in the webinar who has is the most experienced. So I'm asking you, do you see that these results are also corresponding to what you see in your clinical practice?
I would say, well, it's not so easy to answer this question. What you develop when you do a lot of these cases, you get a kind of gut feeling when to use IVL and when not. So you're getting a feeling for the lesions, and I think that I'm getting more and more sensitive to see lesions where I think, okay, this will work with Shockwaves. So our results with Shockwaves are excellent, and so I think we are now even better than those data. And you can see there are 45 sites involved. So in all those cases, so there will be sites with 4 or 5 cases enrolled. So we do 100 cases a year, and with the practice and repeating and all the learning curve, which is very fast in IVL, but still you have a learning curve, you get more and more better results, like with every other device you use. So I think the more you do IVL, the better the results. And you get a feeling when to stop or when to continue or when to unpack another device. And so I think this is very important. The results are very good, but they get even better the more you use it, because you get a feeling for the device. And then it's the sizing, okay? So you get a feeling for the size of the balloon. So I'm getting more and more aggressive to use the biggest balloon I have as possible to treat those lesions. So I think it's very important that these are the results of the trial, but we are not yet finished with our learning curve with the possibilities of this very fascinating device, which will have a larger amount of impact on our daily work.
I think it's very wisely said. Essentially, the more we do, the better it is. And the good thing about Shockwave is just from the, let's say, technical point of view, just a balloon. So essentially, at least for the procedural point of view, it's pretty easy to be used. You just need to push the button, and as I say usually to my fellows, even my daughter can do it. So which is a matter of fact. So now let's go back to Elias. Let's see what's going on in Bad Krozingen. Is inflating the second balloon. So 8mm balloon for an SFA. I think it's a great example of how an SFA should be treated. Because, I mean, many people, I'm sure, would have been scared about even putting an 8mm balloon into the SFA, which actually is a vessel which reacts very well even to these sizes, if, of course, the size is correct. Elias, do you have any comment on the angioplasty? What do you see in his popliteal?
So as you can see, this is now a 7mm balloon. You can see is the inflation and the compliance of the balloon and the vessel. You can see the balloon is completely expanded and fully expanded, and I think the sizing was the right one. The 3 minutes I already inflated in the popliteal artery, and unfortunately I have only 80mm long arterial impact balloons or DCBs, so I have to take two 8mm DCBs for the distal part of the SFA, which was prepared with the Shockwave, and this is now the first one. And I will I would take a second one for the FemPop with the distal part of the SFA on the proximal part of popliteal artery, and then I will give you the final angiography. Maybe if you have another
Exactly,
thought.
this is what I was thinking. Yeah, essentially also maybe a shorter balloon on the popliteal could be useful in case this little lesion doesn't react. But I think the balloon looks very well inflated, and then it's a 7mm and 8mm balloon, so big space. So why don't we go for a case presentation? Definitely, Enrique, do you have some cases you want to show us? Am I right? There's one interesting BTK case in particular, because I think it's, of course, the Shockwave works well, as has been said already on Monday in the iliacs, in the common femoral, SFA pop, and BTK also. It's a new indication. There are new studies also going on. Do you want to share your experience with us, please?
So we have here now a case. We did one of the first cases, and this is from January. This one of the first cases here from January, and you can see here was a patient with a Rutherford 5 situation, and you can see here a complete occlusion of all the BTK vessels. This was the crossing of the very calcified P3 and later the tibioperoneal trunk, and we did IVL with a 4mm device in both vessels. So in this case, you can see now the result after IVL, and we don't have a better picture of the runoff before the intervention, because the patient couldn't hold the foot still because of the rest pain, and so this was later she could hold the foot still. So this is the best we can get prior to IVL, and this was the result with a runoff via peroneal and anterior tibial artery. So
very impressive, because I mean there was no float the foot before. And do you want also to explain a little bit how you cross the lesion? Because I think it's there's no tool which can be used if we don't cross the lesion. So I'm always very fussy about people showing the tricks in order to cross the lesions. Which wire did you use? How did you cross this lesion?
So I think this is with the wire is one of the important things to know, that you use the wire you have the best experience with. I use Advantage wire too, like the colleague in Bad Krozingen. I use usually an 018 standard Advantage, or if it's very calcified, a track. And if I feel any resistance or cannot cross at all, so I switch to 014. But usually 018 is still my favorite wire to cross all the lesions, even femoral and BTK, and switch only to 014, or to heavier wires like Astato 30 if it's massive calcified and there is no way to cross with a hydrophilic wire. But in this case, it was an 018 standard Advantage wire.
Okay, that's important, especially that as you said, the typology of the wires. It's important for me. Like I'm very much more an 014 guy. What do you do, like Bella or Thanos? Which wire do you use usually? 014, 018 platform for BTK.
Depends on how calcified they are, but I'm the same as Enrico. I love the Advantage 018, and this Advantage track, the newer generation, has made such a huge difference. So I rotate between the 018 and 014. But I have to admit that I do sometimes also use the Asahi Gladius. It's also helped with, especially below knee.
Okay, and Thanos, what do you use usually?
I think you probably know this. I'm an 014 person, and even for the SFA, the last 1 year, I've switched to an 014 first strategy, really. And I would say Commando 014 is what I'm mostly used to these days.
Thank you for backing me up on a 014 platform. I owe you a coffee. So essentially, yeah, but I mean, like it's very impressive, like the luminal gain you achieved after IVL. And essentially, also, I mean, if I comment the pictures, there's no need for stenting, despite the incredible amount of calcium. How deep do you usually use your shockwave? Just for the origin of the vessel, also for mid segment? I've seen even people using for pedal arteries. What's your experience, Enrique?
Yeah, depends on the device you have. If you have a 3.5 millimeter, you can even go deeper. And I would say you can go to the foot. We saw pictures now from at the CSF from Mariano Palena, who went to the foot with shockwave balloons. So I think if you stay low with the pressure and watch the patient's reaction, if he has pain or not, then you can go as deep as you can.
Because I think about these posterior tibial arteries, which usually has this kind of last bit of before the plantar bifurcation with a lot of calcium. This, I think, it's a place where it's definitely a non-stent zone. So when you deal with the proximal calcium, you can always say, okay, I will put a balloon on the stent, but not for this segment interdistal PT. So I definitely think there's a role for the technology in this segment. Do you agree, Enrique?
Yeah, but I think in this case, you know, you can always do it better than this. But the thing is, the patient had a rest of the pain and felt a lot better with the foot, and so you can just wait and see if the result is good. On the next day, we do a control and a duplex and oscillography of the foot, and if it's not good enough, you can do a second session. But the problem is, if you want too much in one session, you can jeopardize the result you achieved. So if I have this result and the patient show a lot of clinical improvement, so I like to stop at this point and rather do a second intervention later than do a 4, 5, 6 hours intervention just to get the maximum out of it, and maybe jeopardize all you won. So
exactly,
a short intervention is for the patient is always better than this 4 or 5 hours interventions. And if you achieve a good result, stop there. The better is the biggest enemy of the good. And so stop with a good result, and then you can maybe do a second intervention later to optimize it.
Absolutely. And actually, many people say that the better is enemy of the good. Actually, it was said by Voltaire. So yeah, I had to look into this because I wanted to do a presentation. Now you all know, the people online know it has been Voltaire to have said that, but we can always repeat it also ourselves. So now let's go back to Elias. Elias, I think you finished with your DCB, am I right?
And I will give you now my last and final angiography.
Wow.
Yeah.
Wow. I mean, the segment that you treated is even looks better than the rest, which was actually was asymptomatic. So a very good result, I would say. There's no dissection. There's absolutely no need for stent. There's a great flow. Of course, probably the patient doesn't have the best cardiac output because the flow is quite slow. And actually, it's the same thing when you do aneurysms. Big vessels always goes low, but I mean, the flow is great. And let's see now the results at the level of the popliteal. And again, great results. Great results.
There is a residual stenosis, maybe a very short at the middle part. But
this is what we saw also before. Yeah, this is what I said, probably a shorter balloon. Do you want to try to go there with a 7x4 or would you leave it? It's a claudican anyway.
Yeah, exactly. But I would make only with a POBA at 7x40 millimeter.
Okay, perfect.
More.
So we can go to Bella and then we're gonna come back. I agree with you. So a quick shot from everyone. Bella, would you use a 7x4 here or would you leave it?
It's a difficult one because it's a claudicant, isn't it?
Yes or no?
So,
yes or no?
Yes, I would.
Yes. Thanos, would you do?
I would do it, yeah.
Enrique, would you do?
I would do a second angle and then decide.
Okay. Anyway, I think you have our blessing. I'm not talking about Erwin, but I'm talking about our choice. So how do you see the main utilization of IVL? Standalone or combination therapy? So the option number one is IVL standalone. The second one is IVL plus POBA. As we said before, very calcific lesions. There's no really data supporting, there are not really data supporting the use of DCB in such a calcified cohort of patients. IVL plus DCB, so the contrary, and IVL plus stent. What's your usually, I mean, of course, every case is different compared to the other one, but how do you see the shockwave in your clinical practice? In the meantime, that you're voting via the app, we are going to ask Elias to comment on the pictures. So what about this popliteal?
Give you now the final angio from the popliteal artery. I already treated with a 7 millimeter POBA.
7x4, a short one, yeah? More radial pressure, radial force.
Yeah, exactly, yeah. And it looks now better, and I would say there is no dissection and no relevant stenosis. I give you a second view.
That's beautiful.
That's very beautiful, yes. To be honest with you, I also would like you to show also the foot in order to see there's no, just to confirm, all the data say that there's no distal embolization, because this is what usually people are worried about using this device. Is there distal embolization? So if Elias didn't have a distal embolization with such a big amount of calcium treated at multi-segmental level, probably, you know, distal embolization is something that we should really not be worried about. So let's see if there was definitely a decent outflow. We said a patient probably a big smoker, Rutherford 3 to 4. So let's see the foot.
So
here we are. No bubbles. Also, it's important not only into the balloon but also into the catheter. So yeah, here we are. So let's see what's going on down into the foot. And I bet 1,000 pounds that there's no distal embolization.
Who are you betting with?
I don't know. Against.
Yes.
Okay, that's great. That's the very complete foot arch as before. So essentially, we are very happy. Essentially, Elias, I don't think there's much to comment. It's a perfect result with a perfect device. You know, I think that the patient should be very happy to have been treated with this technology. What do you think?
Exactly, that's it. I'm very happy with this result. The patient will be very happy, and I have no distal embolization. We don't have any dissection. There is no need for stent implantation. So that's really easy and very effective treatment for this kind of heavy calcified lesions.
Exactly. And when you say effective, there are two ways. Of course, the clinical effectiveness, but also I have to say the cost effectiveness, because I mean the price of 2 stents at that level, if we would have used probably a high pressure balloon or a scoring balloon, then would have been higher. And actually, if you use the directional atherectomy or the other the concentrical atherectomy like the jet stream, then we would have put also a filter. So I mean, from the cost point of view, I think Shockwave is a good deal. Am I right?
Exactly. I agree completely with you. Yeah.
Okay, perfect. So we have finished from Bad Krotzigen. Congratulations, as usual. You are a master. You're just confirming what we all know. You're a master of lower limb interventions. And in the meantime, I would like to put up the results of the last poll in order to comment them with all of you. So essentially, the different.
Kann ich einen Mix haben, bitte?
Okay. There are different answers. Let me see. Let me put it there. So IVL as a standalone treatment is 25%, and IVL plus DCB 75%. So it's mainly seen as a vessel preparation and less like a complete vessel treatment. Now, very like a spot on comment about these results. Bella, how do you see the IVL in your practice?
Probably, like Enrico said, more usage, more aggressive sizing, more confidence to knowing exactly what lesions to use and when. So yeah, that's the direction.
Sorry, probably I was not clear. How do you see in your comparing your practice to the poll? Do you see it as standalone plus PTA?
No, sorry, DCB? I agree with the poll. I would be using it with DCB.
Okay, Thanos, what would you do?
For me, it's a prep tool mostly, so I would definitely do DCB or at least Tapoba afterwards. Yeah.
Okay, Enrique.
Again, I have to answer a little bit more complex, because I think it depends on where you use it. In the iliac arteries, for example, prior EVA, I don't do DCB, so I do only shockwave if we want to go up to treat, for example, an aneurysm. For other regions, there are no data. For example, mesenteric artery or renal arteries, but still we do DCB after shockwave. Usually in the femoral popliteal region, I always do DCB after IVL.
Okay, I think it's a very complex answer, and actually it also reflects the complexity of your practice and our practice. For me, like if I have to close with my opinion, if someone cares, for me, I'm not a big believer of DCB in that these calcified lesions. So my opinion also, looking at the data, which are not still very clear about paclitaxel, is usually use shockwave plus POBA. And actually, I think personally that this is a more recoiling issue than a neo-intima hyperplasia. But anyway, I think it's we are here to discuss, and we all more or less agree on what's the best treatment. So now, despite I'm Italian and despite I'm a messy guy, we are almost finishing time. I think I have to thank all the participants, of course, as a faculty. We need to, of course, thank Dr. Noory, who was live from Bad Krotzigen. Again, thanks, Elias. You have seen that you have used now a Minx control device in order to close your access. So, and it was also important to say that shockwave passes through not the big sheets, even the 8mm, 7mm passes through a 6 French. Am I right, Elias?
Exactly, yeah.
So that's also a very good point. If you want to use Angioseal, Minx control, ProGlide, whatever you want to use for closure. Then I also have to thanks, of course, Bella Huasen from, as you said, Lancashire in the UK. At least she's a proper British compared to me or to Professor Saratzis from Leicester, who's a Greek by birth and English by now by practice.
By osmosis.
Exactly. So it was a pleasure to have you both in our call, and actually also, of course, the pleasure to have had Enrique Lafont from Switzerland, who kept also probably us in time because it's just 4, and the Swiss guy was very effective on this. So nothing to say more apart from the beautiness of having passed an hour with you, and just remember you that this is the Shock Week, and Friday is the next appointment. So I hope to see you all online for the 3rd episode of this amazing week. Thanks again to all the participants. Thanks again to all the people who voted. And thanks to all the people who are looking for better ways to treat their patients. see you on Friday. Thank you so much.
Thank you.
Bye bye. Thank you.
Thank you to the
Bye.
patient.